Hello and welcome, and a very good afternoon to everybody who has joined us today on this fall afternoon. I'm sure you could have done many other things with your lunch hour, but thank you for joining us. My name is Dr. Kavya Mikala. I am an associate professor of endocrinology in the Department of Medicine at the Yale School of Medicine. I work primarily in New Haven as well as Stamford, Long Ridge location. I see patients out of both of these locations, but do my bone health clinics at the Stamford 260 Long Ridge location. I have a special interest in bone and thyroid disease, and I'm very pleased that you all came to join in on this conversation today, and very excited to share our information to better your bone health. So disclosures, I have no disclosures, but I do want to point out that I will be using the common trade names of the therapeutics because that is what most of the audience is probably familiar with. So let me start off with a conversation on what kind of patients I see in my clinic, and mostly they're here for osteoporosis or osteopenia, or because their primary care was concerned about some bone density findings. So I can broadly say there are two types of patients that show up in my clinic. The first kind, those who are twiddling their thumbs and we're like, okay, I don't know what this bone density scan it is that they're talking about, but there were a bunch of numbers on the report, and my primary told me that I needed to come in and see a bone health specialist. But I'm not sure, doc. I feel fine, so I'm not sure why I'm here. I eat healthy. I've never had a problem in my life. And so that's one category. And then I have another category where, they've done all their research on bone health, what to eat. They get the best calcium supplement online. And they have done intense research and probably participated in community engagement programs like this one. And they have an immense amount of anxiety around starting any therapeutic agents. So I'm hoping that this conversation will help both of these categories of patients. So to answer the question, why do you care about bone health? The answer is quite simply fracture prevention. The number crunching, everything boils down to just prevention of fractures in your lifetime. So statistics show that every year, about 1/3 of persons who are aged 65 and older will fall. And a fall begets a fracture. I quote that a lot in clinic. Fall prevention is one of the key cornerstones of management of bone health because when you fall, you are putting yourself at risk for a fracture. And hip fracture is one of the ones that we really want to prevent, as it can lead to a poor quality of life, and it can also impact the longevity of a patient and an individual. So you really want to try and prevent a hip fracture. So moving on to the semantics. So what is osteoporosis? By definition, osteoporosis is low bone density. Now, low bone density occurs because there's deterioration in the bone architecture. There's loss of bone tissue, which leads to compromised bone strength and leads on to a fracture. Sometimes osteoporosis can be defined based on having a fragility fracture. So you sustain a fracture with low impact trauma, you meet the qualifying diagnosis of osteoporosis. So how do you go about investigating whether a person has osteoporosis or not? You use what is called a bone density scan or a DEXA machine. Okay, if you've already undergone a bone density scan, then you're probably familiar with this machine. It's basically X-ray beams that are swiping up and down, primarily in the central portions of your body, be it the lumbar spine, the lower part of your spine, or the thigh bone. So typically those are the two areas that are imaged. Sometimes we also use the wrist if for some reason, say a person has had an hip replacement, or if the spine has any artifact, say you've had metal placed in your spine or cement in the spine, then you would want to consider using the wrist as an alternative site. But typically it's the spine and the hip that are imaged. So who should be imaged? Basically, any women who are 65 and older are eligible for a screening bone density scan. And in men, it's age 70 and above. Yes, men can have osteoporosis too. I'm not sure. I haven't looked at the audience participants if you have any men on the call, but men can also have osteoporosis in older life. If you're younger than 65 as a woman, between the ages of 50 and 69, you do qualify for undergoing a bone density scan if you have a risk factor, and we'll go over that in a second. Also, if you have sustained a fracture, then that in itself is considered one of the risk factors, so you also meet criteria for osteoporosis screening. And so that's for women, and for men, it's aged 50 and above with risk factors. So what is the reason? And by the way, if you have any questions during this presentation, I should have mentioned that earlier, please go ahead and feel free to enter that into the chat, and someone will be monitoring the chat. We will try and address it at the end of both the presentations that we have today. So the World Health Organization has the definitions of osteoporosis based on the bone density data, which is based on a particular score that the bone density analysis generates called the T-score. And again, you may be wondering, what are these numbers? They're all in ones and twos. Basically, the T-score is the number of standard deviations from what is considered normal. And normal bone density is anything about -1 is normal. Okay, so it's not your actual bone density score. That is a separate column. This is just a comparative value. And remember, this is not being compared to those who are aged similar to you. It is being compared to the normal, healthy, so average aged individuals, so the younger population. Okay, so anything between -1 and -2.5 would be considered osteopenia, so which is low bone mass, and not as severe as osteoporosis, but not normal. And anything less than 2.5 is osteoporosis. Keep in mind that a fragility fracture, which we talked about before, which is a low impact fracture, automatically qualifies you for the osteoporosis diagnosis, and you're considered severe if it is accompanied by the -2.5 T-score. Okay, so the challenge here is that just using the T-score diagnosis of osteoporosis, you will be missing over half of the folks who would fracture in their lifetime. And so we're just addressing the tip of the iceberg, if you will, just using the bone density score. So it's a little deeper than that. We need to examine who are all, even before a person enters the osteoporosis category, they're at risk for the fracture. So you need to address that. And which is why they came up with this idea of calculating what is called a FRAX score. And you're probably familiar with it if you have seen a bone density report. But again, and this is a very busy slide, and really honestly, the only reason I put it in is to say that it is based on several risk factors that the FRAX score is calculated, including how old an individual is. What is your gender, whether your parent has fractured a hip, whether you have a diagnosis of rheumatoid arthritis, which is considered an independent risk factor for osteoporosis, whether you consume excess alcohol, whether you're a current smoker. So all of these, along with your thigh bone, which is the femoral neck bone density score, are put together in an algorithm, and a risk ratio is calculated. And basically, there are two numbers The first is your risk in the next 10 years for long bone, major osteoporotic fractures. And the second number is your risk for hip fracture over the next 10 years. These two numbers basically tell you what your risk over the next 10 years for fractures are, right? And so what is considered significant? Any score for the major osteoporotic fracture over and about 20% is considered significant. But you can see for hip fracture, it's an even lower number. Anything about 3% is considered significant. So we typically do not use these numbers for osteoporosis. If you have reached the threshold for osteoporosis, you already meet criteria for therapeutic agents. This number is used when you are in the osteopenia range. So your bone density says you're osteopenic, and you're having a discussion with your primary care. Okay, what do I do next? This FRAX score can help determine whether you need a therapeutic agent for healing for treating your bones. And so again, this is what a typical bone density report looks like. You sometimes have this pictogram where they have an asterisk for where you fall. And this is what is considered normal. This is in the osteopenia range, and this is in the osteoporosis range, anything below that. And so this is a very busy cluster of numbers. So what I will highlight is something that we as professionals look at. That's the bone mineral density score. That is really important for us because that's the absolute value of what your bone density is. And that is what helps us determine between bone density scans, when they're repeated, if there has been an improvement or there's been a decline over time, okay? But what you will be getting in the bone density report is primarily related to this column, which is the T-score, which I alluded to earlier in the conversation. So you can see in this, sorry, I'm missing my cursor. There you go. So you can see the femoral neck T-score is highlighted because that's the one we use. We also use the total, which is, I think, 3 numbers down, and it is a negative 1.8. So it's in the osteopenia range. And so we go down to the table below, which gives us the FRAX score. And you can see they have given us, typically when you go in for a bone density scan, they give you a FRAX questionnaire where they're asking you all those risk factors. So typically they already know if you have fractured or not. But here they've given us 2 sets of numbers. So if this individual has fractured in the past, you can see in the right-hand column that the FRAX score is indicative of therapy, both from the major osteoporotic standpoint as well as hip fracture standpoint, because both meet that 20% and 3% threshold. Okay, so I'm a very busy slide, so I'm just going to point your attention to the right-hand column, because sometimes you have very elaborate bone density reports, which are several pages long, which talk also about something called the trabecular bone score. So I want to highlight what that means. Basically, you can go one step further with the bone density study, and you can do a heat map of the lumbar spine to show the integrity of the architecture. Because remember, the bone density is a quantitative number. The TBS, so the trabecular bone score, is more a qualitative attribute of the bone. So as you can see, this top bone architecture appears a lot more homogeneous than this bottom bone, where you can see areas of architectural deterioration, so huge gaping holes there. But basically what that translates into is a TBS score, and you'll get a report saying the bone is partially degraded or completely degraded, a microarchitecture. And that actually influences the FRAX score. So you will get another FRAX score with a TBS report, and that also gives us some additional data to say, okay, even though quantitatively the bone mineral density appears, okay, maybe not that low, but because the quality is low, we may want to consider therapy. Sometimes you have something called a vertebral fracture assessment. I'm not going to spend too much time on this, but basically you can do a lateral imaging study along with your bone density to assess for any compression fractures. But oftentimes, because of the risk of radiation, what we consider doing is plain and simple. When a patient comes into my clinic, we ask about height loss, and if there is a 1 inch or greater history of height loss in the preceding year or from the last time that we have seen the patient, we say, let's get just some plain x-rays to make sure that there's no compression fractures in the spine. So real quick, what are the risk factors for osteoporosis? Of course, the older you get, the more brittle your bones get. And that is because this is a natural deterioration that occurs with aging, but also because there is an increase in bone turnover from a lack of certain hormones that are important for your bone health. Primarily in women, it's estrogen, which is why when you enter menopause or as you're transitioning through menopause, there is a decline in your estrogen reserve, and that has a negative impact on bone health. Now, keep in mind that this can occur in men as well, except it's from lack of testosterone, which is why testosterone levels get checked in in men who have low bone density. Any fracture history is a risk factor. Sometimes people, wonder, but I fell and broke a bone because I was riding a bike, or, it was a motor vehicle collision. But something about that bone is different from a bone that does not fracture with the same impact. So that's a point to ponder for you all. So any fracture history, especially as an adult, is considered a risk factor. A parental history of hip fracture is huge. So if your mom or dad has broken a hip, that puts you at a high risk for you fracturing your hip. So it is really important to consider that risk. Of course, lifestyle is huge as well, as we talked about before, and any history of steroid therapy. Okay. And so, and if anybody has been in my clinic, they know that I am not all about this last column therapeutics. I do ask the individuals, my patients, about every other column, because I think it's crucial that all of these are addressed in order to maintain your bone health throughout your lifetime. So we will address each of these, and we already talked about secondary causes like smoking, etc. But we will address each of these other issues. I want to be mindful of time as well, because Jessica's getting ready to talk. And so real quick, bone strengthening exercises, you have weight-bearing activities, which are high impact and low impact. I'm sure Jessica will be talking to you in detail about this. Balance and strength training, resistance training, and functional training. What is key is you want to do it safely. You want to protect your back, especially with the forward flexion, because as you can see, fractures do occur more often when you're not protecting your back with the forward bending. Of course, you also don't want to not exercise. That's a problem. That's problematic too. But exercising carefully, that is the key. Fall prevention. I'm big on fall prevention. Anybody who walks into my clinic with flip-flops, that's the first thing I'm pointing to and saying, yes, I love my flip-flops too, but make sure you have a backing to your flip-flops. Flip-flops are not ergonomic. They are ready to flip and flop. That's I suppose the name came from that, right, Jessica? I'm not sure, but they're not safe. And again, making sure your home, your environment is fall-proof. Trying to be intentional about what you do, slowing down, and because it's the most innocuous things that end up leading to falls, and again, falls lead to fractures. So as simplistic as this sounds, this is actually one of the best interventions that you can do in your life. And it's very simple. It's cost effective. I mean, it costs nothing, and there's no harm done in making these changes in your life. So diet and supplements, real quick, there are various organizations like the Institute of Medicine, the National Osteoporosis Foundation, which is now the HOF, and the Endocrine Society, ACE guidelines. There are several guidelines on how much we should consider in terms of nutrition supplements. And there was a recent data that suggested that maybe we're over supplementing vitamin D. So I won't go into that. Of course, if anybody has questions, we can talk about it. But most endocrinologists that you talk to would say 30 is the ideal goal for vitamin D, 25 hydroxy vitamin D. And there is no fixed upper limit typically, but we try not to go over 50. So if you can maintain your vitamin D between 30 and 50, and typically it comes from supplements, just because we live in a temperate climate zone, we're not very efficient in making vitamin D off our skin. And of course, if you're making vitamin D off your skin, then you're not using your sunscreen enough, which means the dermatologist is not going to be happy about it. So keep that in mind. And you want to avoid a negative calcium balance. Eating calcium-rich foods is really important. Those are the standard guidelines. The 1,000 for men, 1,200 for women. Quick and dirty. That's very easy to remember. And then you can do a quick dietary estimate based on how many dairy products and calcium-rich products. Remember, even if you're vegan, you're able to get through almond milk and soy milk, you're able to get your calcium intake. So you can add everything up and see how much you're getting. Remember, it's 1,200 from diet as well as supplementation. Okay. And so real quick, what are the therapeutics that you may qualify for? As you can see, there was a laundry list. And of course, it's beyond the scope of this talk to go through every single medication. Keep in mind that the oral bisphosphonate therapies, the top line, those are the most commonly used as first-line medications for treatment of osteoporosis and osteopenia that meets criteria for therapy. Okay, and these are taken by mouth. Of course, if you have pre-existing issues with reflux or GERD, you may want to talk to your provider about that, because that may be contraindication to you being on these medications. So you may want to consider going to a more systemic route, which would be zoledronic acid or Reclast. Prolia is another medication, which is a pharmaceutically denosumab that is given once every 6 months and as an anti-resorptive medication. But recent caveats to that, once you stop the medication, there's a precipitous bone loss. So we really have to have a discussion with your providers about whether that's the right choice for you. Estrogen is not FDA approved for treatment of osteoporosis. Of course, if you go on estrogen for the menopausal symptoms, it does have an added benefit on bone health. There is a medication called Evista, which behaves like estrogen at the level of the bone. And so that is something you could consider, especially if you have a family history of breast cancer, because it's preventative for breast cancer. I will go on to the anabolic agents. Those are the most happening agents, especially Evenity, which is the newest kid on the block. It got FDA approved in April 2019. These are medications that help build bone density. And so the Forteo and Tymlos, those are medications that are daily injections that you use at least for 18 months to 2 years, and they help build back bone. They fall under the category of PTH analogs. If you've had bone cancer in the past, that is contraindication, or radiation exposure of the bone, that is radiation therapy to the bone, that's a contraindication. Evenity is a once a month injection that has a dual action, actually. It actually helps build bone. It can actually also prevent resorption of bones. So it's FDA approved for a year, and there's a warning for cardiovascular events And so if you have had a stroke or a heart attack in the prior year, then you do not qualify for this medication, and it's FDA approved only for women. Okay. And so real quick, that's a laundry list of medications, and you would think that you're doing a great job in reducing the risk of fractures. But actually, there was a time when there was a decline in fracture risk prevention, meaning we were doing a worse job in reducing fractures. And that's because people were getting scared of the side effects. If you've heard, there's, things like osteonecrosis of the jaw and atypical fractures. Those capture the headlines, right? And folks are well read, they're knowledgeable, and they're reading about, okay, a medication to prevent fractures is causing fractures. And then they're like, okay, I don't want to deal with that, right? And so there is a treatment gap because of concerns of safety. And what I tell my patients every time, it's a risk versus benefit analysis. The risk of these complications are very slim, less than 0.001%, okay, of risk of atypical fractures and osteonecrosis with jaw. Yes, they can happen, but with certain, preventative measures and making sure that you are using these medications under the close attention of a bone health specialist, we can ensure that you don't run into some of these risks. Okay, so it is a matter of conversation with your healthcare provider. Okay, and so I'm going to skip over this in the interest of time. All I'm going to say is that in closing, there are several different, measures that we can take to improve your bone health. You don't have to be a gym rat to do it. You can just let movement define your lifestyle, and that really, I think, will ensure that your quality of life and longevity will, be ensured to be successful. And I thank you for your kind attention. This is just some resources from the Bone Health and Osteoporosis Foundation, which previously the National Osteoporosis Foundation, as well as the National Institute of Aging. They have excellent resources online. So for patients, if you want to learn more about osteoporosis. And thank you. And I'll hand the floor over to Jessica Maloney, who's been patiently waiting. Thank you, Jessica.
Thank you.
I'm going to stop share.
Okay. Okay. Is that looking okay?
Yeah, go to the display settings and maybe switch it out. Yeah.
Okay. 1 sec. Hold on 1 second.
You were right there, Jessica. So you go back to the previous screen and then hit the display settings.
Yeah. Hold on 1 second. Sorry. Trying to find the display settings here.
Oh no, that was on the previous screen, Jessica. So this time around, you can just go to your slideshow all the way in the just go to your slideshow, go back to it, and I'll walk you through it.
Oh, sorry about that.
That's okay. Yeah. So resume slideshow. You can hit that. It's just right in front of you, close to your cursor. Yeah. Resume that.
All right.
And
is it working?
Or maybe go down to the bottom, bottom right corner.
See where I just need to kind of close this. What are you seeing? Sorry. Oh, God.
No, we see your slides on the side. So if you want to go down all the way to the bottom.
Yeah.
And right where you are, you see
Oh, your display settings. Yeah. Okay.
Nope. Don't do. Yeah. Just go to the 1, 2, 3 to the right. 1, 2, 4th to the right. Yeah, 2 more. Yeah. Click on that.
That one?
Yeah, click on that. It's not working.
No. Yikes.
No, the one in the bottom.
When it says slideshow on the main bar.
On the top main bar too, right next to animation.
I have like something blocking that. I'm so sorry. Hold on one second. Let me get this Zoom. I have something blocking it. Oh God.
That's okay. So the bottom is not working. That's okay. Yeah. The bottom one is not working. The one next to it. Yep, that one. When you click on it, yeah, click on it. Oh, it's opening the slide. I'm not sure why it's doing that. Or can you just minimize the slides on the right and just continue how you were.
Minimize.
I think because we can see your slides, so I think it's okay.
It's okay.
If you want to just
go for it. Sorry. Oh. I'm not sure. I'm sorry. I know this.
Or if you click on that icon next to auto save and save, yeah, the one you were hovering right on, which has the play button all the way on top.
To the left.
All the way on top next to auto save. Are you able to see that, Jessica?
No, because there's a black thing blocking it.
Oh, okay. Yeah.
Yeah, it's covering the whole toolbar. Let me.
I see.
Like I don't know how to get that.
No, I would suggest just going ahead with.
Okay,
we can see your.
You can.
That's
you can
okay.
See the slides?
We can see the slides. Yep.
Okay.
You just
want to. Sorry, everybody. My name's Jessica Maloney. I'm a physical therapist working at the 260 Long Ridge Satellite Clinic. And I'm going to speak with you today about how exercise and physical therapy can positively affect your bone health. So first of all, and can you see these slides?
Yes, we can.
Yeah, sorry. Why would a doctor refer you to physical therapy if you're at risk or have been diagnosed with osteopenia or osteoporosis? So there's a lot of things that physical therapists will do with you. One is assessing your posture. One is looking at your balance and assessing your fall risk. Another is looking at the strength and range of motion throughout your body. Another is assessing how well you move and walk. And the last is giving you some weight-bearing and resistance exercises. So when it comes down to posture, a physical therapist is going to mainly be looking at your spine and the alignment of your spine. And more specifically, they're going to be looking to see if you have an erect, well-aligned spine, or if your head and upper back are starting to lean forward into a more kyphotic posture. So why is a kyphotic posture a concern when your head and your upper back start rounding forward? Because there's a couple of reasons. As your back starts rounding forward, the forces on the bones in the spine, the vertebral bodies, starts to increase. And if you're someone who already has low bone density or osteoporosis, the integrity of these bones may be weaker. So it puts you at an increased risk for vertebral compression fractures. Another thing that the research has shown is as the spine rounds forward, the density and the strength of the paraspinal muscles, and this is a group of muscles that runs on either side of the spine, they get weaker. And so then it leads to a less ability to hold yourself up in that erect posture. And finally, as the kyphosis continues to increase, it's been shown that people's stability in standing and walking decline, and that they become at an increased risk for falling. So if you have, if the physical therapist finds that you have kyphosis, what can you do about it? So they'll do a few different things. They'll give you some strengthening exercises. So they'll work on strengthening those paraspinal muscles, the muscles that run along the spine and help to hold you in an erect posture. They'll strengthen the muscles between your shoulder blades that help pull your shoulders back, keep your shoulders from rounding forward. They'll strengthen and stretch some of the muscles in your neck to kind of help you so you can hold your neck up and decrease the ability, decrease the falling forward of your head. And then they'll also focus on your gluteal muscles, so the muscles in your butt that help push your hips forward and keep you in an erect posture. So those are the big muscle groups that they'd focus on. They also may give you some gentle exercises, movement exercises that help to increase the mobility of the joints in your upper back. So as the back starts rounding forward, the joints get stiff, and just some gentle mobility exercises that help you stand in a more upright posture. Finally, in this picture, we see something called a weighted kyphoorthosis. So this is another tool that can be used. Looks like a small backpack, and in this pouch, a 1.5 to 2 pound weight gets put in the pouch. So small amount of weight, and then the person wears it where the pouch sits just below their shoulder blades on their back. And what they do is wear this twice a day for 1 or 2 hours a day. And they wear it while they're walking or while they're just doing chores around the house. And this just provides a little bit of a cue to the person to stand up a little straighter. So sometimes when your back starts bending forward, we kind of lose track of what is an upright posture. So this kind of gives people a cue as to stand up and activates those back muscles. And what they found in research, usually the studies are about 4 weeks in length where people are using it every day, once or twice a day. They find increased strength in those muscles in the back. And they also, when they retest balance and some other functional measures, they've shown improvements in people's balance and their ability to complete functional tasks. So that's another thing that they may use. Okay. And thinking about exercises, are all exercises good for people who've been diagnosed with low bone density or osteoporosis? And no, there are definitely certain exercises that you should avoid. So it was brought up earlier that exercises that involve spinal flexion, so kind of deep rounding of that spine, just like how kyphosis, the forward rounding of your spine, increases the forces on the vertebra. Exercises that force your back or have your back move into deep flexion, and also a combination of flexion and rotation. Those two are put people at increased risk for vertebral compression fractures. So those would be exercises that the physical therapist would be avoiding putting into your exercise routine. But there's a whole host of exercises that you can do in an upright posture. We call them extension exercises because you're in an extended upright position when you're doing the exercise. And these are very healthy for people with low bone density and would be the exercises that most of your strengthening program would be comprised of. Just an interesting fact. I saw that 1 out of 5 women who have a vertebral compression fracture will have a second fracture within a year, even with calcium and vitamin D supplementation. So a big goal of physical therapy is really to avoid that first compression fracture. And not to say that if you've had compression fractures, if you've already had one, that there's no hope. There's many articles showing that adding in an exercise program, even if you've had a fracture, is very good at, preventing fractures in the future. But ideally, we'd like to prevent that first fracture if we could. So then also what will be looked at is a person's balance. And so that was brought up earlier, why you'd want to note if you have, poor balance or if your balance could be better. Just know that 90% of hip fractures in adults over the age of 65 occur from a fall, and usually a fall onto the hip. And like was spoken about before, anytime you fracture a hip, it's associated with significant declines in function. And then also it's been shown that the bone mineral density in the hip that's been fractured, actually the loss of bone mineral density increases in the year after a fracture. So very important to avoid falls, especially in people who already have weakening of their bones. Another thing that the physical therapist may work with you is just to teach you safe ways to move. throughout your daily activities. So again, we're talking about that spinal flexion. And they look at different things of how you bend down to pick something up off the floor, how you get in and out of bed, maybe how you go and put your shoes and tie your shoes, how you may bend down and get something out of a low cabinet in the kitchen. So all these things, how you vacuum, all these things. And basically what we'd be looking at is avoiding, do you tend to use a big flexion of your back to go about your daily routines? Or are you using something that we call a hip hinge? And the top movements in this picture show someone who's bending through their back to pick that box up off the floor. The bottom pictures show someone who's using a hip hinge. And this is where you're bending, you're getting most of the movement from your hips and knees, and your spine is staying really in an erect, straight posture. So this may be hard for some people, and you may have to start a strengthening program before you can move in these ways, because you need a lot of strength in your legs and your glute muscles and your butt to be able to do some of these movements. So they look at how you're moving and see they can make some changes with that and where you need to improve your strength in order to move more safely. So big question, can exercise slow the rate of bone loss? And the answer is yes, but not all exercises are equal in terms of addressing bone density. So the best exercises are these weight-bearing exercises that load your bones, and that's definitely associated with an increase or maintenance of bone mineral density, or at least a slowing of the loss of the density. So this is things like walking, hiking, dancing, squatting, all different things where you're weight bearing through your legs and putting some strain through the bones. So those are great. Other exercises that are wonderful exercises to do, like swimming, water aerobics, cycling, all these are great exercises, and they're great for your cardiac health. And actually, I saw a couple articles with swimming where it didn't necessarily increase the bone density, but like Dr. McCullough was talking about earlier, it improved the quality of the bone. So maybe the bone density didn't improve, but the quality improved, and that maybe would help avoid fractures. So not necessarily taking these, if you love these exercises, out of your program, but adding in some other exercises that may address the bone density a little bit better. One interesting fact was there's a lot of studies with professional and master road cyclists, and these are amazing athletes who are exercising all the time, but they found that 2/3 of these cyclists had osteopenic bones in their lumbar spine and hips. And that's because they're spending most of the time on the bike in a non-weight bearing impact exercise. So this was leading to changes in exercise prescription for these cyclists, where they're doing more weight bearing exercises to prevent that. Another interesting thing that the studies have shown is that habitual weight bearing exercises do not help to stop or slow bone loss. So for an example, if you're someone who walks 3 days a week for 30 minutes and you go to your doctor and they found, like through a bone scan, that you're losing bone mass, continuing with this exercise program, even though it's a weight-bearing exercise, is not going to stop or slow this bone loss that you're having. And also interesting, so if you say, I'm just going to increase maybe the number of days that I walk during the week, so I'm going to go from 3 days to 5 days, or I'm going to go from 30 minutes to 60 minutes of walking, that too has not been shown to slow or stop this bone loss. So you really need to change up your exercise where you're putting more strain and load through the bones in order to impact this loss of bone. So what are some things, if you love walking and this is what you like to do a couple of times a week, what are some ways that you could increase the load on your bones and continue walking? So one thing that people have looked into and had positive results is the addition of a weighted vest. So this is a vest that you would wear while you're walking, and it could be anywhere from 1 to 10 pounds in weight. And then that would increase the load through your spine, through your bones, and has been shown to improve your bone density. The caution with that is because that's an easy way to to alter your program, is you just want to make sure that you can, I would go to a physical therapist or professional where they can look at you with the vest on, figure out what the proper weight is, and you really need to have your postural muscles strong enough where you can support the weight of this vest in a good posture. And you need to be able to support it throughout your entire walk. So if you put this weight on and then you start it starts weighing you down and you start falling into that forward flexion, that would not be a good addition to your exercise program. So you may need to start a strengthening program to get you ready to use this weighted vest, but working with a professional to find a good baseline is a good safe way to start. You could also, if you normally walk on flat terrain, you could add in some hills, walking up and down hills, if that's a safe way to go. You could add in some skipping, or you could just add in a warm-up before your exercise where you're doing some jumping jacks or squats or lunges, some stair climbing, or some resistant band exercises. So you could add in some of these exercises as a warm-up before your walk to increase that load on your bones. And to safely, how can you safely increase? We just kind of talked about that. It's always best to get a professional evaluation and a baseline exercise prescription that you can build from. And this is depending on where you are in the continuum of bone density. So if you have a lot of loss of bone and you're very osteoporotic bones, this becomes more important because you want to start at a safe level where you're adding some load onto your bones, but you're not crossing the line where you're at a risk of exercise-induced fractures. So depending on where you're at in the continuum, you'd want to get a safe baseline from which you can start progressing. And in all the research I've looked at, what they call a multi-component exercise approach has been the most effective to affect bone loss. So that is a combination of resistance exercise training. So that's muscular resistance exercises 2 to 3 times a week. And then weight bearing impact aerobic exercise. So that could be that weighted vest walking. It could be jogging, dancing, squatting, any of those type of things, stair climbing. And then the balance and posture exercises are usually included in all of these programs just to keep that balance as good as it can be and to avoid the falls. And just a specific information on the resistance exercise training. So everyone's kind of always wondering, do I do 10 repetitions, 20 repetitions? How many bicep curls do I do? What's the best? So what's been found with to address bone mass and slowing the loss of bone mass or increasing it is higher loads with lower repetitions. So the training zone of 70 to 80% of your 1 repetition max is where you want to be. So basically what that is if I'm doing a bicep curl, my 1 repetition max is the amount of weight that I could only lift 1 time before my muscles were so tired they couldn't do another bicep curl. So that's not the safest to test in people, especially for people who have osteoporosis, because that could lead to some fractures. But what they say is you want to exercise in that 70 to 80% of your 1 rep max. And what that would be 8 to 12 repetitions. So I would find a weight that I could lift between 8 to 12 times before my muscles were too tired and couldn't lift the weight again. And that would be my ideal training resistance, put enough load on my bones to affect my bone mineral density. I just want to finish by 2 studies that kind of highlight the benefit of exercise in improving bone mineral density. And one was the bone estrogen strength training study. And this study was conducted with postmenopausal women. And so there was 3 groups. They had a group that didn't exercise and everyone was taking calcium. Then they had a group that exercised and took 800 milligrams of calcium. And then they had another group that was exercising, taking calcium and doing hormone replacement therapy. So they exercised 2 to 3 times a week. And they did this multi-component exercise regimen where they warmed up with a cardio aerobic warm up for 5 minutes. Then they did 20 minutes of strength training. So throughout the study, they did this for a year. They had 6 exercises and they did 2 sets of 8 reps. So they were on that lower end of the 8 to 12 reps. So they were probably working at an 80% of their 1 repetition max. And they did those 6 exercises. Then they did 15 minutes of weighted aerobic exercise. So it was either jogging, stair climbing, walking with a weighted vest, some sort of impact aerobic exercise. And then they finished with 5 minutes of abdominal strength and 5 minutes of balance exercises. So they did that for a year. And they found significant gains in, I think, like 1 to 2% in both the lumbar spine and the femoral bone density. And it was very similar between the exercise and calcium group and the exercise and calcium and hormone replacement group. They were very similar. The only thing that the hormone replacement, actually, they showed increases in more bones throughout their body, but it wasn't a super significant increase in the amount of bone density that they gained. So exercise showed great effect there. And the last one was an Oregon State weighted vest study. So this one, they had a group of, again, postmenopausal women. This one, they were just looking at their hip bones. And they had a group that started with, they educated them in a 9-month, they were doing an exercise program for 9 months. And then they split the group in half. And one half kept up with this 9-month exercise program. And the other half added in this weighted vest exercise. So again, it was 3 days a week. And they had a weighted vest from 1 to 10 pounds. And in all of these studies, they have a starting weight, and then it gradually increases as they get stronger over the weeks. And they did things with the weighted vest. They did sit to stand out of a chair. They did lunges. They did squats, exercises like that 3 times a week. And then on their own, 3 other times a week without the vest, they jumped in place 50 times, 1 time a day for 3 days a week. And they did this. This was a 5-year study that they did. And they had some great results. So the control group that was not doing the weighted vest exercises and the jumping on their own, they lost 3.8% of their total hip bone mass during that 5-year time period. And the exercise group lost less than 1% of their total hip bone mass. So that was a great result. The control group lost 3.4% of the bone mass in their greater trochanter, which is a common area of your hip to fracture. And the exercise group lost 0.2% of the bone mass in the greater trochanter. And finally, the control group lost 4.4% of bone mass at the femoral neck, which is another common site for hip fractures. And the exercise group gained 1.5% of bone mass at the femoral neck. So they had great gains with this addition of the weighted vest to just simple exercises that everyone does. So that is the end, and I hope that provides a little inspiration for the addition of exercise in to help positively affect your bone mass.
That was great, Jessica. Oh my gosh, I learned so much.
About the slides.
Oh no,
You could see them.
That's fine. We could see them.
Okay.
I'm very the weighted vest. That's okay. And I see we have a couple of minutes to address a couple of questions, but before that, the weighted vest, I recommended those casually to my patients, but it's interesting that you recommend having an assessment of the spine before doing it because it could have them lean forward. Does it mean we could start with a 1 pound weighted vest and then gradually increase if we're concerned about or do you ever recommend carrying dumbbells and walking or ankle weights?
All of that is helpful.
So is okay. Yeah, because patients ask me where to go, and that little contraption you showed, that's quite interesting too.
It is very
What is it called again, and is it available?
It's a weighted kyphoorthosis.
Weighted, so is it something that's a prescription or it's a durable medical?
About it, I don't think I haven't had insurance cover it for anyone, but
I see.
Sometimes what I'll do too is just like a child's backpack, like a little backpack.
There you go.
And you put like 1 or 2 pounds of weight in, so you don't have to have. I mean, it's kind of where it sits, like right below the shoulder blades, and it gives like
below the shoulder blades. That's key. Okay, wow.
And it just needs to be tight on you. It can't be like flopping around.
Got it. So I think we're there. That's a question we just asked. Where can one buy a WKO vest? So yeah.
I will have to look, I should have looked that up, and I will have to.
Okay.
Is there
Well,
any?
why don't you look that up? And so the first question, sorry, we're kind of running on the minute here, but if you're welcome to stick on and we can answer the questions. If there are more, please keep the chat coming in. So hormone replacement therapy that's a whole separate topic as far as, and it's really beyond the scope of this discussion, but bottom line, hormone replacement is not FDA approved for the treatment of bone health, osteoporosis, unless you have entered, menopause prematurely. Before the age of, 45, 50, and based on your risk factors, individual risk factors for breast cancer and things like that, those, factors are really important to consider. But the thing is, if the indication, FDA approved indication, is for vasomotor symptoms, hot flashes, night sweats, those are the reasons to consider hormone replacement. So if you are on those the estrogen supplementation for the vasomotor symptoms, you have the added benefit for your bone health. And those first 5 years after hitting menopause are the most crucial for addressing your bone health. And beyond that, then it's a matter of juggling the risks, especially the cardiovascular risks versus benefits. So in terms of Judy's question on the best calcium supplement, I don't believe in breaking the bank for buying the most expensive calcium. And I have several patients walking into my clinic doing that. They'll be taking 4 capsules of, marine derived calcium in the morning that gives only maybe 200 milligrams of calcium. In my book, keeping it simple is, and cost effective is really, I think, a very practical solution. I keep it broadly as calcium citrate. Any citrated calcium is better absorbed. So especially if you are on an acid blocker, or you have trouble with malabsorptive symptoms, or there's just general trouble absorbing, say you have lactose intolerance, for instance. So if there's just a general trouble in absorbing, then you may want to consider switching to a calcium citrate product rather than using calcium carbonate. And keep in mind there's a limit to how much calcium you can absorb in any given time. So say always best to have the calcium supplement with dinner, or lunch or breakfast, so after the meal or with the meal, and because the acid helps enhance the absorption. And doing it in divided doses, because you do not absorb more than 500 to 600 milligrams at any given time. So having it in divided doses is key. And again, keep in mind, it's the supplement plus the diet altogether, 1200 milligrams that you need for your bone health. All right. I don't see any other questions in the chat. So Jessica, did you find the...
I'm seeing it through. Right now, I've mostly had people wear the child backpack brace, child backpack, but that's probably the best bet. It looks like I don't have a spot right now. I'd have to come up with a spot to get a specific.
Well, child backpack sounds great. Yeah. We have plenty lying around at home. So
right.
Again, I thank the audience for your kind attention and the questions, and look forward to future community engagement programs. Take care. Bye, Jessica. Take care.